Dr. Greenberg is certified in addiction medicine, has served as chief medical investigator and assistant director of the Arizona State Medical Board, is an expert consultant in the field of detecting, controlling, and reducing diversion and abuse of prescription-controlled substances in chronic pain practices. Dr. Sucher and Greenberg, welcome to the Medical Board of California, and we look forward to your presentation. At the end, we'll take questions, unless you want an interactive dialogue. That's your call. Whatever works.
Thank you.
Thank you. Bless you.
Good afternoon, Madam Chairwoman and members of the board. It's an honor and a pleasure for both of us to be here, and we're looking forward to speaking with you. And we're happy to have questions during the presentation, if you like, and there will be plenty of time at the end. Here's sort of the agenda that we've set out at some of your requests, but to tell you a little bit about who we are and what we do, and then try and respond to the specific requests you had on determining if somebody has a substance use disorder or other impairing condition, and then particularly the methodology that we use to determine whether a physician is safe to practice or to return to practice if they've been out of practice. And we recognize the seriousness of those issues and how important it is, so we sure appreciate your attention and interest. You heard a little bit about both of us. We've been doing this for over 20 years apiece now, and we both also practice here in California as well. And I'm just going to quickly go through this, that you can certainly read at your leisure the sort of things we do, but we do operate monitoring programs for professionals and individuals in Arizona and California. We do consulting, education, compliance, and those sorts of things. And we do work with the Pacific Assistance Group's group facilitators, and we really have the ability to monitor people throughout the state of California, really wherever there's a need. We do utilize whatever types of disciplines or resources we need, including virtually all medical specialists and particularly psychiatrists, neurologists, and addiction physicians as well. I think probably the biggest piece of our background is that we have been the medical directors and managers of the physician health program for the state of Arizona since 1992, for the medical board, and for the dental board since 1993, and we continue in those roles today. So very much the same issues that you are interested in is the services that we perform for the medical board, and you can just take a quick look, but we virtually work with every regulatory board and hospital system in Arizona. And in California, we've been here in California since 2004, but really on a much more active basis since the announcement that the diversion program was going to close in early 2008. And primarily, we worked with what you see here, and there are others, but these are the major medical groups, hospital systems that we've worked with in terms of education, consulting, assessing potentially impaired physicians, and monitoring physicians who've come back from needed treatment. We did do some work for the Medical Board of California in 2004 and early 2005 when the diversion program's resources were somewhat strapped. And we did overflow work. We also assisted in monitoring physicians who weren't eligible for the Medical Board of California's diversion program. They were out-of-state physicians, working in a federal facility under another state license, or individuals who were here but didn't have any license, or some of the early training individuals who didn't have a license. So we helped with that, and we did this really essentially as diversion directed us. And we do this for private individuals and courts and criminal justice and so on. We also work with Mission Pacific Coast Recovery, and I think in a lot of ways that's part of what prompted our visit here today. Behind me is Dr. Daniel Hedrick, who's the medical director of Mission Pacific Coast Recovery. This is at Mission Hospital in Laguna Beach. We have a full-service professionals assessment program, and the thing that probably sets this facility apart is that it's within the scope of a full medical, surgical, psychiatric facility with a chemical dependency program as well. And I'm not aware of any other program in California that offers that. We deal with primarily healthcare professionals, but other safety-sensitive and high-functioning individuals. And we literally look at virtually the full range of things that get doctors in trouble. The other thing we know, and I think this speaks very much to what you're interested in as well, as in Arizona, we have for years sent people to evaluation programs such as this, and we very much tailor where we send someone based on the issues they're dealing with to pick which programs are appropriate choices. But the most important thing that I want to know, and I think that you want to know, is what's wrong with the individual? What are their diagnosis or diagnoses? Not maybes, but what are they? And what, if any, treatment do they need specifically? And then, most importantly, are they fit for duty or safe to practice? And if not, what will it take to restore them to fitness for duty? And we believe in delivering those answers in a clear and concise manner. The assessment process includes all the things you see up there. But the most important things that are probably a little different than what you find in most places is that we also have really comprehensive laboratory testing. Blood, breath, urine, hair, fingernails, toenails. With toenails, you can look back almost a year. And you can look for virtually every drug nowadays except for nitrous oxide. It's the only drug we can't test for. So we really have quite a comprehensive rather than a simple approach to this. And additionally, we occasionally, when indicated, I'm sure you've never had any doctor not be truthful with you. In our business, denial and minimization is kind of the order of the day, and sometimes just outright lying. And so in about 10% of the cases, we do medical polygraphy to really determine, and oftentimes I'll take the position with a patient, a doctor patient. I'll say, well, doctor, let's turn the tables and pretend you just told me the story I just told you, or vice versa. Would you believe that? And I had one doctor tell me, I wouldn't believe a word you said. And I said, well, now you understand why I don't believe a word you're saying. Well, we had one physician. He turned up slightly positive for ETG, for a metabolite of alcohol. What happened? Well, I think it was the bananas Foster I had for dinner the night before the test. Well, of course, he's already under an agreement with the Arizona Medical Board saying he won't eat food containing alcohol. I said, well, we're going to double the frequency of your testing, and we're going to, watch you. And he goes, that's ridiculous. That's overkill. 3 months later, he had another one. I said, what happened? He said, well, I think I had some truffles that I didn't realize had amaretto in them. I said, okay, you're still eating food with alcohol. I said, well, frankly, I don't believe you, and we're going to send you for a full assessment, including a medical polygraph. That's ridiculous. Can't we please keep the double testing that he revolted against 3 months earlier? And, of course, just the threat of the polygraph said, well, I actually been drinking some wine along with, and clearly out of practice, right back to treatment, which is exactly what the answer was. And just from a philosophic perspective, we understand these issues. We understand public safety, patient protection, and the care of the individual and the needs that you have. We try and work together in a seamless partnership approach, meeting you where you're at. And we also understand enforcement and investigation issues. We've been actively involved in medical board investigations in Arizona and dental board investigations, state bar investigations. And so we understand really what you do, and we understand what your needs are as well. I want to just touch quickly on a couple things here. The two things, these are the things that we do in general, but the two things that we do specifically, you've probably heard the term MRO, or Medical Review Officer. That's a physician who interprets drug tests. The bulk of those people test along the guidelines of the Department of Transportation, airway, railway, long-haul truckers, very limited, because we're dealing with physicians who have virtually access to every kind of imaginable drug, legal and illegal. We have to be much more sophisticated in terms of how we do this and how we analyze that. And then the other one is the fourth one down, proactive evaluation and monitoring. We work with the largest anesthesia group in Arizona, 250 physicians who came to us. Anesthesia has a rate of addiction approximately 10 times the rate of other medical specialties. And they also have some of the poorest prognoses in terms of ability to return to anesthesia and practice. And we actually test their members randomly with no history of any prior problem for OR drugs, for fentanyl, sufentanil, Versed, propofol, morphine, cocaine, those kinds of things. And believe it or not, in the last 6 months, we found 2 people using propofol. 2 people with positive propofols that never would have been detected until 1 out of 4 anesthesiologists, the first sign of a problem, they're found dead of an overdose. 1 out of 4. So before something bad happened to the patient or to the doctor, we were able to do that. We're working on spreading that word, and I think you're going to hear a lot more about proactive drug testing in general for physicians. And we're committed to doing this as quality as we can. One of the questions I got asked before we started was, who pays for this? And typically the patient who's referred to us pays for our assessment or monitoring services. We receive no subsidy or no financial support whatsoever from the Arizona Medical Board or the Dental Board or any of those agencies. We did in the past, many years ago, but not any longer. And now some of our client hospitals pay for some consultations and things like that. But let's talk about what we're here for. And again, questions are A-OK at any time.
Doctor.
Yes.
When you made a diagnosis of chemical dependency in a doctor, the insurance pay?
Does the insurance pay? For treatment, it depends on the facility. But yes, typically insurance will at least pay for a portion of the treatment. They may not pay for all of the treatment. And as you'll see as we go further down this discussion, physicians typically need more treatment than lay people need to be able to have a high probability of success in recovery and safe return to practice. So because they need longer treatment and more intense treatment, it usually costs more. So typically insurance pays for what lay people would normally get. But anyway, did I answer that?
Yes.
Yeah, thank you. I think it's always good to have a definition. In 1973, the AMA came up with this definition of an impaired physician as someone who's unable to safely practice medicine with reasonable skill and safety to patients by reason of physical or mental illness, including alcohol or drug dependence. Before that, they thought these doctors were bad character, bad moral character, bad people. And it was in 1973 they finally started to think of them as ill physicians. These are the sorts of things that get us in trouble. Substance abuse is probably, either in totality or in part, 80 to 85% of the cases. But there are people who do have pure psychiatric issues. We deal with disruptive behavior, boundary violations of all types, mostly sexual. Chronic pain is something that we're seeing a lot more of. And when I started practicing, if you were on Percocet or Percodan, 5 milligrams, 2 every 4 hours, you were on 60 milligrams of oxycodone a day, and that was considered to be a lot. Today we see people on 160 milligram OxyContin 3 times a day, plus Vicodin or Percocet. We're seeing people on 10 times the dose. And sometimes they're physicians, and the question is, are they safe to practice on that level of narcotic?
Yeah, and I think one thing, Madam Chairwoman and members of the board, that's really important is that we live in kind of a dichotomy, and that's the research on cognitive impairment due to opioids and benzodiazepines and other drugs that the rest of the world knows and believes from their scientific studies, and what we believe here in the United States. And I can just tell you that in the rest of the world, it is an accepted fact that human beings placed on high-dose, round-the-clock opioid regimens sustain significant and impairing cognitive problems, both with short-term memory, sometimes with long-term memory, nonverbal problem-solving, executive function, and what they call working memory, which is what the Europeans think is the most devastating effect of the opioids and the other drugs. So this is a real thing, and yet when you read the American literature, which is largely supported by Big Pharma, the American attitude towards this type of problem is really very, very kind of nebulous. They say that, yeah, maybe some people get some cognitive impairment, but we don't know enough about it, and it needs to be researched for another 10, 15 years before we make any recommendations. And that's a tragedy, because we see people all the time who are impaired by these drugs, and it's something that can be treated, and it's something that can get better. Pardon?
She has a question.
No, I just on that. So then, as part of your process, would you be testing to see if a particular individual had cognitive impairment with the opioids, even if they had a legitimate pain thing, and advise?
Absolutely. We evaluate people that way. And I just got back from Cambridge, England, well, this last summer, not just got back. I was working with the Cambridge Cognition Group. They have the largest data set as far as testing patients and seeing which drugs impair people. And it's not just controlled substances. Some of the psychiatric medicines and anti-seizure medicines and other medicines, even, of course, chemotherapy. The old joke about chemo brain is a real thing. And so, yes, what we're trying to do is get permission from Cambridge to use it clinically. Their testing right now is basically only for research type purposes, but I think we're going to get permission to use it clinically in the near future. Although I got to tell you something, a standard Alzheimer's screening test is a very good basic screen for drug-induced cognitive impairment, because these people look, act, and think like people with early to middle Alzheimer's if they've been on the high-dose opioids for a long time. We didn't see this back in the days when people got 5 milligrams of oxycodone 3 times a day. But now people get half a gram of oxycodone a day, plus benzos, plus other things. So it's a real area for the future. And one last thing about the hair testing. We're now moving to toenail testing. And the reason is that people with gray hair, blonde hair, and people who dye their hair have a much higher percentage of negative testing with hair testing. And if we use the nail testing, it's a fair test to use. So we're transitioning to that.
Yeah, and the other issue, and this we get asked a lot by medical staffs, is what about the aging physician? Should there be mandatory cognitive testing when you turn 60 or 65? And I don't think anybody has an answer to this yet, but it probably is going to be something coming down the road. There's a microcog, which is a screening tool for cognitive impairment, probably is going to become kind of a standard for those of us with gray hair. So I just want to move on mostly quickly on substance use disorders. I have kind of a simple way to look at them. We look at social use of alcohol or drugs, and some people would say there's no social use of IV fentanyl. Others would disagree about that. But typically nothing happens. They don't end up in front of you. They don't end up coming to see us. Abuse is when drinking or using drugs starts to cause problems in your life. And a DUI, for an example, is an incident of alcohol abuse. Bad judgment, could have hurt yourself, could have hurt somebody else. And the real question is whether that's a pattern that goes further than that. If you look at just the subtle difference, under abuse, drinking or using interferes with living. In addiction, life gets in the way of your using time. In other words, the fact that you have to go to work, practice medicine, take care of your family, pay your bills, gets in the way of using. The real difference is loss of control. Somebody who gets a DUI, and it's a one-time thing, says, I shouldn't have done that. I'm not going to do that anymore. And they don't. Alcoholics keep drinking and driving. It is an interesting fact, though, that the average person who gets a DUI has driven drunk 200 times for every time they get stopped. And a lot of people, I think it's actually more than that, frankly. I don't know how much we sped on the way down here, but I only get a speeding ticket every 3 years. So they're much better at catching drinkers than speeders, which probably is a good thing. The kind of standard way we diagnose substance use disorders, and I think is pretty much standard across the substance abuse industry, is through the DSM-4-TR, the Diagnostic and Statistical Manual, somewhat the psychiatric Bible for all mental illness, including substance use disorders. That's been around for about 10 years in its current form, and I'll go through that in a moment. But the DSM-5 is about to come out, probably in the next year or less. It's going to collapse these two categories into one. A single category of substance use disorders. Probably it will be mild, moderate, or severe, and we don't have the final language. Some of that will be confounding, but I think, again, physicians use clinical judgment. We're going to be looking at ways to determine whether somebody's safe to practice and what level of treatment they need based on what they present with, as well as very objective data. Now, the substance abuse category for the DSM-4, a maladaptive pattern of substance use leading to clinically significant impairment or distress manifested by one of or more of the following four things. There's a fourth one on the next page. But recurrent substance use resulting in failure to fulfill a major role, recurrent substance abuse in hazardous situations, and recurrent legal problems. This is kind of the point where you get more than one DUI would be a good example. The key point is it's within a 12-month period, and that's very limiting. And I'm going to talk about how we go kind of beyond the DSM after I go through this. The fourth one is continued use despite having persistent or recurrent interpersonal problems. And mostly that the person never in the past has met the criteria for dependence. You know, there's a saying in AA, once a cucumber becomes a pickle, it can't go back to being a cucumber again. And so once you've really been diagnosed as chemically dependent, you probably can't go back to being a normal drinker again. The real essence is no loss of control. In other words, they're able to stop in order to avoid consequences. And as such, they don't need typically the chemical dependency treatment we think about. But they do need monitoring, and particularly when we're talking about physicians, where there's a public safety component. When somebody's gotten in enough trouble to get a diagnosis of substance abuse, they have to do something. Typically what we do is, okay, you have to stop drinking. You have to stop using all drugs unless they're really prescribed for a proper therapeutic purpose. And you have to be randomly drug tested. In Arizona, our standard is 24 months of random testing. And if you can not drink and be compliant with the testing protocol for 2 years, probably we got you in time. Our experience with this, by the way, and we've been doing this separation of abuse versus dependence for about 6 or 7 years, is typically about 3/4 of the people we place in this abuse program do okay. But about 1/4 aren't compliant, or they have a positive drug test, and they've now essentially made the diagnosis of chemical dependency, because if they had the ability to control their use in, facing potential licensure consequences, they wouldn't have used. And then they go to treatment, and we'll talk about what we do for chemically dependent physicians. We also require education, because we think a lot of these people got in trouble without really understanding why they did certain things, why they use drugs to cope with problems in life, and how they got in so much trouble. And that some, education kind of in the 72-hour range, much like somebody who got a DUI would be required to take, so they don't do it again. Now, like medicine, all of medicine, there are some gray areas. Sometimes there are people who maybe we're not sure if they're just sort of turning into addicts and chemically dependent individuals, or if they're still on the just really bad abuse side of this. Sometimes you just can't tell. And the example we have here is somebody who comes in grossly intoxicated, harms a patient at work while on duty, but when you actually evaluate them, they don't technically meet the criteria for dependence. They still need treatment. They need to be treated because the risk of being dependent and the significance of what they did that got them to our attention is so significant, we would tend to treat them more. Go ahead, Dave.
I was going to say that's something that distinguishes us from a lot of other practicing addiction medicine specialists and others, is that the DSM-TR4 is a nomenclature index, okay, and it's used largely for billing purposes. Our commitment to public safety is such, and by the way, we've been doing this for a combined almost 50 years, and we've never had anyone that we've monitored so far, knock on wood, get into some kind of horrific complication in which there's been any patient harm. That's a pretty good record for being in this high-risk business for almost 50 years between the both of us. So when we have someone who's presented, for example, comes into the emergency room, a doctor intoxicated or impaired, even though we can't make the diagnosis according to the DSM-4-TR of chemical dependency, if it's abuse and it's put patients at risk, we believe that those doctors need treatment, and they then need longer periods of monitoring thereafter. And that's what we recommend, and that's different than a lot of the, around the United States, medical association programs and other stuff like that. It's different, and we have the reputation of being tougher, but again, our roots are in public safety in that sense.
And then getting to substance dependence, again, this is the DSM-4 criteria. You have to have 3 or more of the following criteria, again, in a 12-month period. Tolerance, takes more to have the same effect, or you get less of an effect with the same dose. Withdrawal, meaning you stop taking it and you have withdrawal. You take more than you planned on or for longer than you intended. There's a persistent efforts to stop or cut back that are unsuccessful. You spend a lot of time preoccupied with the use, getting, the recovery part of this, that you have important, significant social or occupational consequences from the use, and you continue it in spite of it impacting your physical or mental health. This is the more serious condition. This is the one we deal with the most in physicians. It's, the real loss of control. And these individuals aren't safe to practice. At the time they're diagnosed, they are untreated, chemical dependent. They must come out of practice, and they must go into treatment. And I'll talk about the ranges of treatment in a moment, but one thing we've learned over the years is that doctors need more treatment than the average bear to be restored to safety and have a high probability of success. And by the way, there's some very good data in the British Medical Journal, November 2008, 904 physicians, 16 states, monitored for an average of 7.2 years. With good primary treatment, as we'll describe, followed by structured accountable monitoring, 78% never had a single positive drug test in the 7.2-year period, and 14% had one positive drug test and no more and did well. Only 8% went on to have serious death or license loss or career problems. That's pretty good. One thing that Dave often says is if there's a chronic, fatal, morbid illness, that there's really good treatment available, and you can only get it if you're a physician. If that was cancer or heart disease, we'd have a war on our hands. But it's substance dependence, and we think this type of treatment should be available to everyone. And then following treatment, you need to participate in a physician health program that's monitored. But I want to go a little bit beyond the DSM, because we think the DSM, are, as Dave just mentioned, are very restrictive. They're designed, I think more for lawyers and insurance companies than for the practice of medicine. And we look at someone's complete history over time. In other words, you saw that those criteria said within a 12-month period. Well, if you went to rehab 6 years ago, and now all of a sudden you got another DUI, and that looks like an isolated incident, you can't just look at that in isolation. You can't say, well, this is just an incident of alcohol abuse. No, this is a chemically dependent person who's relapsed. You have to look back at their entire history. You also got to get collateral information. You got to talk to colleagues, people who work with them, partners, family members, people, because typically when we assess people, they want to put their best face forward, and, well, I don't understand what all the stuff is about, Doc. I only have a glass of wine or two at dinner, and then you talk to the spouse. What do you mean? They have 2 bottles every night when they get home and they pass out on the couch. I can't even have a conversation with them. You need to get that kind of information. And you need to use clinical judgment. The other thing is that the DSM wasn't designed for safety-sensitive people specifically, wasn't designed to look at fitness for duty. So again, you have to go beyond that, and we do. And there are times, and I was telling Madam Chairwoman, before, when we do a typical screening assessment, if somebody gets a DUI or they're caught forging a script, or, there's an incident about drug diversion, they come to see us. We spend a couple of hours with them. We review whatever material we have. They all get urine tests. They all get hair or nail tested. And so there's one of 4 outcomes typically. One, it's an isolated incident. There's nothing here around patient safety or something that needs treatment. We do nothing. The other extreme, you're clearly chemically dependent. You need to stop work, go straight to rehab. Sometimes we can determine that they're in the substance abuse category, stop drinking, stop doing drugs, be monitored, and if you're in a monitoring program and you're compliant, then you are safe to practice. But sometimes we don't know. There's more to the story. Or the person's in denial. They just say, Doc, I don't believe you. It's not that bad. You're wrong. You're overkill. I'm not quitting working. I'm not going to rehab. And sometimes it's a result of an order from you or an order from a group or a well-being committee. And those people get to go for an intense 4 to 5 day, sometimes as long as a week or more, evaluation, much like we described that we do at Mission, and there's about a dozen places around the country that are well-known. Talbot, Betty Ford, Hazelden, Farley. I mean, there's a slew of places that we use that have been doing this for a very long time to figure out exactly what's going on. And that also takes the wind out of somebody who's protesting sales when they say, well, no, the medical group, they sent me here, and, they want you to say what they want you to say, what they want to hear. And we're given independent opinions. Well, okay, let's get an independent opinion. We'll send you to this other place. They have nothing to do with us. They'll check you out. And by the way, sometimes things aren't always what they seem. We had an anesthesiologist a number of years ago. All of a sudden, 20 years, good practice record. All of a sudden, severe mood swings. Well, when he went for one of those assessments, he had a brain tumor. He didn't have a drug problem. We all thought he had a drug problem. He had a brain tumor. So you don't always know. Now, the kind of the spectrum of treatment for chemically dependent individuals, there's medical detoxification. That's purely removing the physical part, nothing about the mental obsession. 12-step programs, really important for long-term maintenance of sobriety. There's intensive outpatient and various levels of outpatient and inpatient treatment, and then there's longer-term treatment. Now, we've found that physicians typically need inpatient or residential treatment, minimum 30 days duration. One, we did a study at the Arizona Medical Board a number of years ago. It's probably more than a decade ago now. We had some physicians who did outpatient programs. 95% who did outpatient relapsed within 18 months or less, whereas we have a 90+% 5-year success rate for people who do residential treatment. We just don't allow outpatient treatment for doctors who need treatment. But, yeah.
So
Sorry.
When you do residential treatment, I mean, it consists of what?
What does treatment consist of? You would be in a residential setting, minimum 30, often up to 90 days. Education, group process therapy, drug testing, self-help meetings, including working usually the first 1 to 5 steps, depending on the program of AA, family therapy, and peer interaction with other physicians who are also in treatment. There's usually physician-specific groups. And one of the key things before somebody comes out, and when we talk more about return to practice, fitness for duty, is that you really have to do a complete practice assessment of what does this physician do on a day-to-day basis in terms of, are they going to the hospital? Are they in the office? Are they doing surgery? Are they in an outpatient surgery center? Are they working 80 hours a week? Are they working 40 hours a week? And you look at every piece of that in context with their addiction and what they got them into treatment, and you sort out what they should be doing and what they shouldn't be doing when they go back, and how they might phase back to what full-time is. And we try and look at full-time as 40 to 50 hours a week for most physicians, but, there's a lot of us who 60, 70, 80, and more. And of course, the residency programs now have restricted hours because of safety concerns for everybody. So did I address? Okay. And it's really a very intense process. The most important thing is, if you look here, again, you need to get away, because most of us are so busy taking care of everybody else, we don't take very good care of ourselves. And so this treatment is really an opportunity to focus on you getting healthy instead of trying to manage your practice and manage your family and manage everything else. And I hear this all the time. I can't stop working for 90 days. I can't just take off. I'm going to say, well, what if you walked out in the street and got hit by a bus? You broke your pelvis, crushed your chest, ruptured your liver and your spleen, and you were in the ICU for a month. My guess is you'd have to take the month or two off. And, we look at this as a medical illness. This is a medical illness. This is not bad behavior. This is not poor character. I can't think of a single addict in the 20-plus years I've been doing this, doctor or otherwise, that wanted to be a drug addict and ruin their life and make everybody miserable around them. Not a single person. And it's an illness. So basically, physicians need more. And also, these days, we know that about half the physicians we deal with also have some other issue. They have a mental health issue, depression, anxiety, bipolar disorder. We're seeing more with chronic pain. We're seeing them, with severe diabetes or neurologic disorders. And you have to address the whole person. So those things have to be treated. You can't just treat alcoholism and forget about the rest of the person. That's true in all of medicine, and again, it's the same kind of thing. Just to tell you where we think treatment's going, the trend is toward longer treatment, and the trend is toward not sending physicians to simple community-based programs, but to pick programs that really have expertise in dealing with the special issues around physician health. And we're going to see more people who require 90 days rather than 30 days. And we're also seeing people who sometimes they're even longer, especially if they're kind of multiple relapse people. And of course, you may have the opportunity of deciding how many chances you're going to give them, just like a spouse who says, you've told me you're going to quit drinking 26 times. I really hope you get better, but I'm not sticking around. In Arizona, we have a 3-strike policy. The first time it's confidential, and I'll talk about what confidential means in a moment, and non-disciplinary. The second time it's probation and discipline. The third time you get revoked, or you surrender in lieu of revocation.
One thing, though, in Arizona, if the first time involves any type of unsafe practice, patient care, or something like that, then it's not confidential. And
probation automatic.
Probationary automatic, yeah.
Yeah. And by the way, confidentiality in Arizona, everyone is known to the board. And the agreement is actually a board agreement which we administer. Yeah.
One just thing very quick, they're also known to the hospitals, their employers, and their partners, and their insurance companies. So it's not truly confidential, but it is something that is done to protect the public again.
It's not on the website or the reported the Federation or data bank. Yeah.
So when you say care-related, does that mean actually an adverse event, or does it mean just showing up inebriated at work?
Could be high-risk inebriation without any damage to the patient, but just being in a very high-risk situation.
Yeah,
even if the nurse stops you at the last minute and says, no, doctor, the chest tube belongs on the right
How
side.
about just showing up in the hospital? Okay.
And in fact, I'll give you a good example, because again, we don't, I'll give you one example of patient harm in a moment, but we had an anesthesiologist who showed up to do a morning of outpatient surgery. He had been using fentanyl, and that particular day he decided to add a little propofol to the mix, and the next thing you know, he was on the floor. He was the most anesthetized person in the place. And of course, he got taken to the to the ER and resuscitated, and another anesthesiologist was called. But that was probation. You don't get confidential non-discipline for that. We had a urologist in rural Arizona a couple of years ago. He was on chronic pain medicine. There were some concerns about him that had not yet been reported to the medical board. He took an Ambien to go to sleep at 9:30 at night. The next thing he knows, it's 10:30 in the morning, and somebody's shoving a card in front of his face saying, "Stop operating now." He didn't remember waking up, showering, dressing, driving to the hospital, or the first hour and a half of bladder cancer surgery that he wasn't doing particularly well. At any rate, it turns out, by the way, we talked to his wife, and she gave him more Ambien in the middle of the night because he, quote, couldn't sleep. He has no memory of any of that. But that patient was in rural Arizona, was helicoptered to Tucson, and died an hour later. There was no other urologist in this small town. Now, he is in our program and doing well now that he's been treated and dealt with, and he's on probation. But that's a terrible outcome, obviously. But he wasn't known to us prior to that event occurring.
I mean, he was known to have troubles at the hospital, though. And the hospital did not report.
So we're heading toward more treatment. Just to give you a quick overview, and this kind of will probably seem as some of a reminder for what diversion used to do. But when we monitor people, have to abstain from alcohol and all mood-altering drugs unless properly prescribed, weekly relapse prevention therapy, biological fluid testing. And that's random drug testing, comprehensive random drug testing, probably around an average of 40 times a year. But we also have on-demand testing. In other words, if somebody's worried or if somebody's not compliant, they get extra tested. Testing frequencies increased. Tests are directly observed. We do random hair or nail testing once or twice a year because that gives us a 3-month window. And that's kind of the standard thing. We also, have tools now for evaluating drinking. Alcohol has always been the weak link because it has a short retention time, 6 to 8 hours in blood or urine, 12 maybe at the outside if you're really loaded. And that a negative doesn't mean you aren't drinking. A positive means for sure you were. But now we have ethyl glucuronide, ETG, and ethyl sulfate, which are markers, can detect a single drink for a day and a half or 2 days. We now have a blood spot test called the phosphatidyl alcohol test. You get a drop of blood, and it will tell if you've had a drink or more per day in the prior 3 weeks. And we have identified a number of. So the science is getting better. The other thing is we can now look for ETG in hair and nails. So we can look back in fingernails or hair 90 days and almost a year in toenails. So we have ways, that we do much more than what used to be done. We require people to attend 12-step meetings like Alcoholics Anonymous or Narcotics Anonymous. They have to have signed meeting logs. They have to have a primary care doctor who's approved by us. Can't be somebody else in our monitoring programs because that's a recipe for trouble. And they can't be in trouble with the board. And by the way, it can't be them anymore. They can't treat themselves anymore. We require worksite monitoring, coordination of all medical and psychiatric care. Sometimes there are practice limitations or restrictions for a period of time. Again, part of that treatment course that we were talking about includes a practice assessment. Sometimes that's in part of the agreement with the board. Sometimes it's an agreement between us that we watch closely. Sometimes you can't have access to controlled substances or prescribing limitations. We see anesthesiologists, kind of like a bartender who's alcoholic. Anesthesiologists sometimes can't go back to anesthesia, and that's not an uncommon outcome. And some people need, obviously, individual therapy or psychiatric care. The standard in the U.S. Is 5 years of monitoring with a diagnosis of chemical dependency. We now know that there are certain risk factors for relapse. You can look at the Domino study in JAMA in 2005, the BMJ study in 2008, and individuals who are opiate addicts, particularly opiate addicts with co-occurring psychiatric disorders, prior relapse portends future relapse, that some people need longer-term monitoring. We probably think anesthesiologists who used OR drugs, if they go back or remain in practice, are going to need career-long monitoring, plus naltrexone is an opiate blocker, and documented. We can test for it. We can give it by injection so we know they got it. Again, drug testing, like any scientific aspect of medicine, continues to advance. And the proactive program like we have for anesthesia, you're probably going to see more of that. The three highest risk specialties in our experience are anesthesia, emergency medicine, and psychiatry on a per capita basis, but we see it in every field. So you're going to see, I think, more of that. Now we want to talk about fitness for duty, and I think this was one of your key requests, and obviously it's a big concern. That's your responsibility that somebody is safe and competent, and I will tell you, we monitor typically about 200 physicians at any point in time between Arizona and California, in addition to dentists and attorneys and chiropractors and veterinarians and so on. I don't know if any of them are particularly good at their particular specialty, but we do make the determination all the time whether they're safe to practice their specialty. If you're chemically dependent, the first requirement is you have to successfully complete treatment. You can't decide when you leave. You have to be discharged with staff approval. We assess everybody within days of their coming out of treatment. We review the records for treatment. We have dialogue with the treatment center during a transition period, so it's a smooth transition directly from completing treatment into monitoring. They have to be enrolled in monitoring, in a highly structured and accountable monitoring program that absolutely includes drug testing. I spent a year as the medical director of the behavioral health system for the state of Arizona. 170,000 mental health substance abuse patients statewide. There's almost no drug testing done. I had a meeting with the medical directors of the 7 regional behavioral health authorities and the tribal behavioral health authorities. I said, we need to have random drug testing of our patients' mental health and substance abuse all the time. And they looked at me, we can't do that. Our patients will think we don't trust them. Excuse me, do you have your patients come in and tell you what their blood pressure is, or do you check it? Do you expect somebody to come in and say, oh, my blood sugar is 132 right now? No, you prick their finger. Well, drug testing is the most objective measure of whether this illness is in remission, or if you have a mental health disorder, whether you're abusing substances that affect your mental health. So drug testing is literally critical. We usually have people, when they are safe to practice, by the way, we believe it's good for a physician who's finished treatment and who's deemed safe to practice to get back to work. We think that's part of their recovery. Being productive, being useful is part of their recovery, but only when they're safe to do so. We often do this on a gradual basis where we'll require them to work part-time for a month. We'll restrict them from certain activities, maybe don't do surgery, just do office consults, those kinds of things. And, of course, we're ongoing, on a continuous basis, reassessing how these people are doing to make sure not that they were safe to practice at a particular point in time, but they're remaining safe to practice. So having a close relationship with the monitoring agency that you trust is key to ongoing safety to practice. And that's not just compliance, but that is a clinical judgment as well. We do have some people that come out of treatment and they aren't ready to go back to work. This is particularly true in people who've had relapses, where they've done this before, where we say, all right, you finished treatment, but we're going to watch you for 6 months or a year and make sure that you can manage your recovery and stay sober before we let you go back to practice. This is often true in anesthesia with injection drug use. The other things that can affect somebody, if you have chemical dependency and you have one of these other types of conditions that you see here, some serious medical problem, bipolar disorder is particularly risky, chronic pain is particularly risky. The other thing we do is when we have individuals who have psychiatric disorders plus chemical dependency, or if they're purely a psychiatric monitoring case, we drug test them for their psych drugs. We want to make sure they're taking what they're supposed to, as well as not taking what they aren't supposed to. Because, you know, if you look at typical pharmacy data, the compliance with the prescription is, did you fill the prescription? Nobody really asks, did you take the prescription? Or document that you took it. I mean, I used to, when I was at the behavioral health department, we reviewed all the death cases. We would go out to people's homes. They filled the prescriptions, but there's boxes of unopened pills. They never took them. And so that's a real key piece of this as well.
And we learned that the hard way about 2 decades ago when we had a rash of suicides in doctors that we were monitoring, and not one of them had the psychotropic medication they were being prescribed for depression in their system. Noncompliance is rampant in this culture, with the exception of compliance with opioids and other addicting substances, where the compliance is super normal.
Yeah.
Yeah, just what percentage of the time with anesthesiologists is the restriction that they will never return to anesthesia practice because of the risks?
Well, typically there's 3 categories of anesthesiologists. There's those who can go right back. There are those who need to take a break, typically 1 to 2 years, and then can go back. And then there's those who can never go back.
Category 1 would be like an alcoholic anesthesiologist who never abused OR drugs.
Yeah, exactly. And so for someone who abused pills or alcohol, they can probably go right back to anesthesia. If you had like the doctor who passed out after doing fentanyl and propofol, he's out for 2 years minimum and probably can never go back. Certainly if you've had a relapse, I'll give you another example. We had a physician, he was Versed and fentanyl. He got through our 5 years of monitoring. And his initial presentation, by the way, before the first time was that he was nodding off in the operating room, forgetting to start IVs, little things like that. And when I talked to him about why he couldn't go back right away, he said, well, you don't understand, Mike, I have a really mild case of this. Look, I used for 3 months and then I got help right away. I said, no, you don't understand. Most people actually take the drugs home and get high and have a good time for a few years before they start passing out in the operating room. You know, that when you start to see symptoms in the workplace, the disease is well advanced. Usually their family and personal life has been trashed for years, any discipline, doesn't matter. But in his case, and so when he got out of our monitoring program, he immediately stopped taking naltrexone, which we had mandated he be on. And within 9 months, he was again visibly impaired in the OR, and this time he didn't go back at all. So, and that's work in evolution. When they sliced and diced the data from the British Medical Journal, which had a high proportion of anesthesiologists among the 904 physicians, Dr. Skipper, who was one of the authors of the study, analyzed just the anesthesiologists, and he found that if you got good primary treatment and were in a structured monitoring program, the outcome for anesthesiologists was no different than for any other medical specialty. That's kind of groundbreaking information to us. Most of us have had really terrible experience with anesthesiologists going back to the operating room. And I don't know, do you want to add to that, Dave?
I want to make a comment, and that is that nowadays, when we talked about a doctor discontinuing their naltrexone and then relapsing, nowadays we pick that up right away, and we can monitor that in a whole bunch of different ways. Number one, we can mandate that they get injectable long-acting naltrexone opioid blockers, so there's no question that the month's dose has been delivered intramuscularly and that's on board. Number two, we can check for it in the urine, and we can also check for it if we wanted to. We could also check for it in blood, and we can check for it in hair and fingernails. So when it's an emergency, if you have a doctor who's supposed to be on naltrexone and he gets a urine that's negative for everything, which includes naltrexone, that's an emergency. If that doctor has access to opioids and his or her problem was with opioids, that's something we act on that day. As soon as we get it, that's an emergency.
Yeah. And then back to, the whole notion, again, of fitness for duty. When someone's coming out of treatment, we look at what the treatment center recommends. Again, we have close dialogue with all the places. We don't refer to anyone where we haven't been there personally and don't know the medical leadership of the treatment program. We think that's really important. And that changes from time to time. People come and go. Physicians, about half the physicians in this field are in recovery themselves. They can relapse. Obviously with time that becomes less likely, but it never is out of the question. So we have a close relationship with treatment centers and the monitoring programs, and we make a decision based on not only how they did clinically and how they're doing in their disease, but also looking at the details of their practice. And we really use clinical judgment. Again, we look at this as a medical issue, and we really use clinical judgment.
So let me ask you the question.
Sure.
For the doctor that's coming and availing themselves of your services, I feel very comfortable. For the doctor that is not practicing or is practicing and decides to go for treatment and goes to one of those facilities that you contract with, do you have oversight of their re-engagement into the community? Or who's monitoring?
You mean
that
presently?
Currently,
yeah. Well, for example, the clients we mentioned, Kaiser, Sutter.
So that means any Kaiser doctor that has
Yeah.
an issue is being monitored by your organization?
Well,
as well?
no. They have called us on numerous occasions to assess, refer for treatment when indicated, and monitor physicians after treatment. They don't always call us. They may call someone else. They may not call anyone.
So for the
Yeah.
person, let's say, going to an institution versus a hospital, someone going to Betty Ford, that person goes to Betty Ford, is treated by Betty Ford, and is finished with the treatment at Betty Ford. They then go through your system or not?
Well, ideally they would. If
Well,
we sent them there, they would come back to us.
You
to be
sent them,
monitored.
but if the doctor privately goes to Betty Ford and finishes with Betty Ford, they're finished.
Well, they shouldn't be finished, and we don't know.
We as a board, I'm asking you.
It is a problem, Madam Chairwoman. It is a problem. Betty Ford, as all conscientious treatment programs, would do everything they could. They would try to move heaven and earth to get this person, including involving family members, to get them to report to the board. In Arizona, for our treatment programs, it's a done deal, because Arizona has a law that we have to report our colleagues if we believe that they may be impaired by any cause, whether it's drugs, Alzheimer's, diabetes, doesn't make any difference. We have to report, okay? But in this state, at the present time, that law doesn't exist. And so either the facility will get sued by violating HIPAA and turning someone in, or they'll do everything they can to try and get the doctor and his family to reconsider and to report. But there is no absolute legal mechanism in the state of Arizona that I'm aware of that forces the doctor to report. Our doctors also have to report on their license renewal, and that's every 2 years, so they have to report that way too. But it is tougher here.
Yeah, and when Diversion was here, medical staff well-being committees, medical groups just say go to Diversion, and then they would get a report. But Diversion, I think, was never terribly widely used, because typically about 0.5 to 2% of the active physician population in any state is in a monitoring program at any point in time. So a state as large as California should have had 1,000 or more physicians in their monitoring program at any point in time. My understanding is the max census that Diversion had was 400, and typically it was around 250, way underpenetrated. Today, the well-being committees and medical groups, unless they call us or somebody like us, really don't have any idea of where to send people or how to confront them. Their well-being committees typically have no real authority. They are advocacy groups. That's part of the issues. Medical associations are advocacy groups. Unless there's a compelling issue that makes you go get assessed, treated, and be monitored, there's no way to mandate that. And we're available, we're willing to and happy to do that work, but someone has to find us and ask us to do it.
The well-being concept the committee is flawed. And it's flawed because we see this all the time in our state and other states. They'll pick a radiologist, an orthopedic doctor, a pediatrician, if they're lucky, maybe a psychiatrist, and an internal medicine doctor, maybe, if they're lucky too. None of them have any expertise in performing investigations of any kind. They're unaware of how to investigate something confidentially and thoroughly and get to the bottom of problems quickly. They are unaware of the risk management and other liability type issues involved in performing a poor or sloppy investigation, and they don't know how to do interventions, and they don't know how to do all this other kind of stuff. So it's kind of like you got a group of different people who had no real training in aeronautical engineering, but you put them together and said, listen, this is a rush project for Boeing. You got to design the new wing for the new 797, and you got to have it done like within the next 3 days. And because these are always pressured type things, they couldn't do it, okay? And so it's an imposible task, physician well-being committees.
Yeah, I mean, that's not universal.
Not universal.
No, not at all.
There are a lot of physician well-being committees that invest a fair amount of time and energy in training and in supporting the physicians.
That's true.
Absolutely, that's true. There's like everything. There are some who are very inexperienced, some who are very experienced and know what to do. One of the things, that, by the way, that we put into our monitoring agreements, because monitoring agreements without teeth really don't have, just like without drug testing, they don't have any real impact. So if you're significantly non-compliant, if you relapse, or if you're unsafe to practice, they give us permission to report to their medical group, to their hospital, to the board, wherever the appropriate entity is that sent them to us. So, and without that, you really can't effectively monitor somebody.
What I'm going to recommend is that we go around the table, and that because it's getting close to the time we need to conclude, I want to thank you very much. But I think that everyone should.
Sure.
Dr. Lowe?
Yeah, I want to thank you for a very comprehensive presentation.
Thank you.
I have a question about the emphasis of chronic pain therapy. California has a very strong educational requirement and training program of physicians in terms of being sure that patients that need pain medication get adequate pain medication. So do you believe that that in any way contributes this increased availability to physician problems of addiction?
Yeah, Doctor, I do, and I'll say this. We've had a sea change as far as opioid use in the United States of America in the last 15 years. And I'm no advocate at all for going back to the bad old days when people with chronic, severe, undiagnosed, or poorly, unable to properly treat due to whatever methodologies were available at that time, and relieve these people of their chronic pain, that people like that were basically denied judicious doses of opioids. But you have to understand a couple of things. Very few of the doctors who prescribe chronic pain medicines in the United States of America have any training in addiction medicine, any true training in chronic pain medicine, or any type of training with reference to even basic mental health issues sometimes. There's all kinds of things which come out now as far as it's recommended you get this education. It's recommended that you PMP, the Controlled Substances Database. It's recommended you do a history and physical. It's recommended you get urine screening. It's recommended you do other addiction screening. It's all voluntary, at least in most states. It's all voluntary. And so because of that, there's a tremendous pressure upon doctors in practice now to prescribe. And I'm not talking about pain mill doctors. I'm talking about busy family practice doctors and that kind of setting. And it is hard for them to hold the line. And when they refuse to give patients their requested oxycodone, I'm a reviewer for the DEA in the state of Mexico and Arizona.
State of Mexico?
New Mexico and Arizona. I'm not that undercover. And at any rate, the thing is that the quality of how patients are evaluated for chronic pain conditions and the decisions on when to use opioids and the decisions as far as using proper informed consent, et cetera, and even communicating with prior prescribing doctors is very low. It's very, very low, at least in the 2 states I review in. And it does spill over into physicians themselves and into their practices. And a common thing we see is physicians going to nurse practitioners to get chronic pain drugs. Okay,
are we as a board contributing to this problem by having this requirement for pain education and so forth?
No, that's a positive thing. The problem is that it's also, you also tell doctors to read the statutes. You know, you also tell doctors lots of things, and so I don't think there's anything wrong with it. I think it's a good thing that you're doing that. It's just that a lot of doctors don't do that, and really, in this country, if you look at all the prescribing doctors, most of the education they get on chronic pain prescribing is from detail people. It's from big pharma, and that's the truth.
One of the frustrations of being a clinician and taking care of a lot of patients is that these patients with pain are difficult to take care of, and it's very easy to refer them to a pain specialist who then puts them on long-term pain medication. And I think that there's a strong trend to do that just because of the economy of time and the ease of getting rid of that patient and putting it on somebody else, whereas I think we don't invest enough in actually trying to figure out why these patients actually have pain.
Absolutely true.
So while I admire this wonderful program of evaluation and treatment, I think our focus needs to be on prevention. We need to prevent patients and physicians from ever getting addicted. And so I think that kind of investment is better investment.
Well, I think you're right. I mean, prevention and wellness and education has huge benefits. And I think that to the extent that that could occur, it would be excellent. And I think that the 12-hour requirement is an excellent foundation but the question is, does somebody really take a thorough history? Do they get documentation that somebody has the basis for chronic pain that they tell them they have, and so on? I think those are the challenges.
Well, you talk about these escalating gigantic doses of narcotics. The only way somebody can tolerate those gigantic doses is through chronic escalation and tolerance.
Right, absolutely.
Because without it, they couldn't take those drugs. They'd be dead.
Right. And a lot of these doctors are self-declared chronic pain specialists. They really don't have, a lot of them don't have training in chronic pain. I mean, there are many board-certified, chronic pain specialists that do a fantastic job, but a lot of the doctors who open up pain clinics are self-declared chronic pain specialists who don't even have a book on chronic pain. They don't belong to a pain society, and they are tough nuts to crack.
Because I feel there is such an inconsistency in the addiction medicine assessments we get. And I just obviously fear that we will allow a physician to continue to practice. And if it's true, and I've heard this too, that it's 200 times of driving before you get caught, well, then it isn't one offense.
Right. Yeah, I mean, well, again, if you have a fairly low threshold for abuse, and you say, all right, to be safe to practice, you have to stop drinking, stop using drugs, and document that through random testing. And if you really have the correct diagnosis, they'll be able to do that. If you don't, they'll fail, and then they'll be immediately taken out of practice and go straight to treatment.
Well, I guess I'm questioning whether or not they shouldn't just go to treatment. Maybe they wouldn't have to stop practice. Maybe they don't need residential, but maybe they should at least get treatment and monitoring. Are there really some that, I guess there are some that just the monitoring is enough?
Well, remember, it's not just monitoring. It includes education, and education is, in a sense, an outpatient treatment program. So that's correct. And I'll tell you, if you go back a dozen years, 10 years, we used to treat substance abusing and dependent docs the same. They all went to treatment. They all got long-term monitoring. We knew that some of those people were overdiagnosed and overtreated, but again, in the notion of public safety, not much harm in doing that. It was really both the DSM-4, really separating those two. That may change again with DSM-5, and pressure from lawyers. I had a dentist who, the one day the dental board dropped in on him, he had 3 illegal drugs in his system. He, of course, not prescribed. Said he had, a week of partying with old college roommates and so on. So the board and I said, you need to go to the Talbot Recovery Campus and be assessed. They had just been successfully sued for diagnosing somebody for millions of dollars, and they were gun-shy. They diagnosed this person with no substance use disorder and no treatment recommended. And that came back to us. And then when they went in front of the board with their lawyer, who said, well, what do you mean you want to monitor this person? We went to the place you sent us to, the most famous place in the country, and they said he's okay. That's the problem we were all faced with.
Exactly.
Yeah.
Thank you. Dr. Diego, do you have any questions?
Yeah. You know how you said that it takes longer for physicians, the treatment is much longer. What's the average for their treatment then versus the regular population?
Probably, and it depends on the particular treatment center you ask. The range is 30 to 90 days, and probably the average is around between mid-50s to mid-60s.
And the ongoing monitoring then would be, what would you say to be successful?
Typically 5 years. But we're starting to see, we know what relapse risk factors are. There are certain criteria such as opioid dependence with co-occurring, prior relapse, things like that that mandate longer monitoring. And most states haven't gone to that on a mandatory basis, but I think we're headed that way based on data. Certain groups like anesthesiologists, if they go back to the OR, probably their entire career with mandatory naltrexone. I think you're going to see that as we're learning more, this is a tough illness to keep in control.
So are there other specialties other than anesthesia that we should be wary of?
Well, I think, again, the highest risk ones are anesthesia, emergency medicine, and psychiatry. Those are the three that we see with the highest frequency compared to the number of physicians in that those particular specialties.
But family practice is pretty high, too.
Family practice, internal medicine, general surgery, just on sheer numbers.
Thank you. Dr. Carrion?
Since chemical dependency today is considered a disease like diabetes, do you recommend that the medical schools start early in students or maybe residents that they are going to have yellow flags, red flags at the moment when they are going to practice?
Well, I agree. I mean, I think, number one, there's almost no education or very limited education. It's starting to get better, of course, on substance dependence. The other thing is I think we're starting to see residency program directors becoming more alert to behavior problems. And it's really critically important because the two highest risk groups in a general sense are the very young physician and the very old physician. Because if young physicians don't get help right away and good help, their career's over before it starts. The people who are closer to retirement will just say, screw it, I'm going to quit and keep drinking instead of going to treatment and rehabilitation.
And the second question I have, do you recommend a regular screening, just like airline pilots?
Well, again, we've just started doing proactive screening in anesthesiologists, unidentified anesthesiologists, and I think that there is a big trend toward random drug testing. But I think how you do that and how you manage that has to be well thought out. But I think we're heading that way.
Right.
I think also we're going to be going to lifelong, career-long monitoring. You can't say that if a person has brittle insulin-dependent diabetes that they should be check their blood sugar and their HbA1c, for 5 years, and then after that they can just kind of do what they want. And I think that if you look at addiction as a chronic illness, then long-term monitoring is essential. And 5 years is a pittance. It's not enough.
Well, I want to, Dr. Sisto, you have any questions?
Just one, if you don't mind.
Please.
Does your program keep statistics on the success rate of the participants?
Yes, we do.
What is it? What might it be?
Typically, well, the last survey we did looked at a 5-year period and showed that 93% had successfully completed the 5-year monitoring program following treatment. And I will tell you that in general, physician health program data, not just ours but around the country, is really the best objective data on recovery from chemical dependency, because if you ask most treatment centers what's your success rate, they will say, well, we call everybody who finishes the program, so they don't count the dropouts, and we call them every, say, 6 months for 2 years. How you doing, Bill? Bill might have a bottle of vodka sitting on his table, but he's doing fine. And that's counted as a success. But the studies on physician health programs are objective, regular, frequent random drug testing, weekly face-to-face contacts in groups, regular progress about things that are objective measures.
Thank you.
You're welcome.
Right, I would agree with my colleagues. This is an excellent presentation.
Thank you.
One quick question. You said that the physicians, you kind of glossed over this, were the most difficult of patients to treat. Is there a specific reason other than they feel that they have the training and they know, or is it something else?
Well, I don't know if I said they're the most difficult, but they typically require more treatment, more intense, and of longer duration than the average person because they're not used to being patients. They're used to being in control. They're used to being their own doctor, and they have to learn how to not do that. we're just slower learners, I guess, than the average bear.
The other thing is that I noted on your page when you're talking about anesthesiologists, I think you were talking about potential sources of monitoring, and you had CRNAs in there.
Yes.
I would really not, I'm a nurse practitioner, and because of the difficulty in the relationship and the friction between CRNAs and anesthesiologists generally as professions, I would not recommend that they be the source point, although many times they are. But I just would not posture that because there's enough friction between the two professions.
Yeah, thank you. Yeah, I only mentioned that because we do work with CRNAs. We do work for the Arizona Board of Nursing, and particularly with advanced practice nurses. And so we see some of the same issues.
Well, we have difficulties here in California over the two professions.
Got it. Totally got it.
Okay, one last question, Dr. Lemire?
Yeah, thanks, Jerry. You raised an interesting question. So is the risk among CRNAs comparable to the risk among anesthesiologists?
I think it is. I think it's very similar. Dave, you think so?
Yeah, I think it's very similar too.
It'd be interesting. We should look at Board of Registered Nurses.
Right.
Discipline action, because I don't think that is the case. If it is, they're not.
Well,
Your microphone, you can't hear.
Members.
I gave a presentation to the Arizona State Board of Nursing a couple of years ago, and I actually got to listen to their statistics. Now, mostly this is registered nurses as opposed to advanced practice nurses, but their monitoring is 3 years. They typically required only intensive outpatient treatment. They had a 50% successful completion rate of their program. So much less successful, but again, a lot less intense treatment. And of course, there's other factors as well, I'm sure.
Well, in California, the BRN actually disciplines far many more nurses in proportion to what we do for physicians for drug use. I mean, that seems to be the number one.
Yeah, I think, and I also work with the EMS Bureau with paramedics and EMTs. Again, you do see more of that.
Right.
So, thank you.
I want to thank you very much for coming to California, coming to San Diego. I know you're already in Orange County, but thank you very much for presenting to us again. It's always very informative and interesting, and look forward to being in touch.
Yeah, and thank you very much for the opportunity to be here, and we'll be around for a little bit if any of you have any other questions once we're off camera.
Thank you.
Thank you. Have a good meeting.
Thank you. Thank you. So we're going to continue. I'm going to turn the meeting over to Ms. Shipsky. Enforcement?